All right. Hello, everyone. So my name is Roy Sriwattanakomen. I'm the advanced heart failure attending at BID-Plymouth. And today I'm going to give grand rounds on the clinical pearls in the management of heart failure. For those of you who don't know me, I know I've met a lot of you. I was in Boston for my residency and did a hospitalist year and actually came up to Plymouth for some time, about 4 weeks or so during a hospitalist year, and then did chief residency all at BI, and then did my fellowship in Pittsburgh in cardiology and advanced heart failure, and then came back to Boston. I split my time between Plymouth and BI, do about 60% of inpatient time at Plymouth and 40% in Boston. But my main clinic, which we've been looking to start up, is supposed to be underway in several weeks. And my main clinic will be here in Plymouth. So for those of you who I haven't met, I look forward to meeting you. And I hope everyone learned something today. There is Zoom polling that we will try to get to work during this talk. All the poll answers are anonymous, so please participate. Just makes it, I think, better for everyone. Okay. So I have no financial conflicts of interest to disclose. Several objectives that I hope to get across, including recognizing the morbidity and cost and prevalence associated with heart failure, appreciating the importance of decongesting heart failure patients, understanding that worsening renal function is not associated with bad outcomes during aggressive diuresis, learning to correlate the physical exam with patient hemodynamic profiles, recognizing when to be concerned for low output heart failure, gaining a better understanding of the stages of heart failure. There are indeed advanced treatment options, including LVAD, plans for stage D heart failure. So, heart failure is incredibly prevalent. There are about 2.2% of Americans affected with it, and 5.7 million total heart failure patients. That's projected to increase to over 8 million by 2030. The incidence is high, with about 915,000 new cases in those older than 45 each year. And the morbidity and mortality is high in advanced stage heart failure. 50% are readmitted within 6 months, and 50% will die within 5 years. And this is despite advances in treatment over the past few decades. For our Medicare population, more than 1 in 10 will die within 30 days, and more than 1 in 5 patients are readmitted. Heart failure is expensive, as we all know. There are about over 1.1 million hospitalizations for heart failure each year. The average length of stay in the hospital is 5 days, and the all-cause readmission for heart failure is 25% within 30 days, and as I mentioned in the last slide, 50% within 6 months. And the total medical costs for heart failure are pretty astronomical, expected to increase to $70 billion by 2030, with the majority being for inpatient hospitalization. CMS also penalizes for readmissions, and the penalties can be very severe. It can be up to 3% of all inpatient hospital costs that they deduct, not just heart failure readmissions. So, I think that one of the things that I wanted to get across is that, why is there such a high readmission rate? And one of the reasons is because patients are just often under-diuresed, and I think we've all seen this in practice. Registry data reveal that 40% of patients are discharged despite persistent signs and symptoms of heart failure, with minimal decrease or even an increase in body weight, right? So if a patient comes in volume overloaded and you put them on 20 milligrams of IV Lasix, but you don't check their ins and outs, you don't check their weights, you don't do a good physical exam, that patient can stay for a week, and if they're not seeing, you haven't done any benefit for them, and they're likely going to come back within a month. So this is some data I wanted to go over, looking at how congestion at discharge relates to rehospitalization and death. So this is a pretty big study out of the Everest trial that was done about a decade or so ago now. And it basically took 2,000 patients and over 9 months, made a composite congestion score for all patients. And it was a very simple score. They looked at orthopnea, they looked at JVD, and they looked at edema. And they basically scored each of these components from 0 to 3, with higher scores being more severe congestion. And at discharge, the cumulative event rate, which was based on all-cause mortality and rehospitalization for heart failure, you can look at these curves and see, even with patients who had a congestion score of 0, no orthopnea, no noticeable JVD, no edema, that their cumulative event rate was still pretty high. At a year, it's about, over 30%, close to 40% or so. At 6 months, it's about 20%. But, it's much, much higher. The more congested patients are, they do much worse. And you can see that over the 9-month time frame of the, median follow-up, that the more congested patients were, the more the primary outcome was met. Similar data can be seen from this long-term registry. This is out of the Heart Failure Long-Term Registry in Europe. And basically, it shows the same thing. They basically categorize patients as warm versus cold and dry versus wet. And those patients that were wet and warm did worse than patients that were dry and warm, which is what we all aspire to be. And then patients that were wet and cold did much, much worse than those that were dry and warm. And this is 1-year mortality. And you can see these mortality Kaplan-Meier curves here with those patients who were dry and warm doing far better than those patients who were wet and warm and wet and cold. And so the question is, I think intuitively we would all think that low output, low stroke volume, being cold is worse than being wet. But if you look at studies, that isn't the case at all, which I think is very surprising. This was out of the ESCAPE trial. Leslie Cooper did a sub-analysis and basically looked at SWAN findings in terms of index and wedge, as well as RA pressure, and basically dichotomized patients for freedom from death, cardiac hospitalization, and transplant by index and by wedge. And as you can see, there is no difference between the primary outcome for based on flow, but based on wedge, right? Those that had a higher than 20 had a much worse.
Not true, Tenny.
That had a wedge. And so what Leslie found in this paper was that the final RA pressure and the wedge, but not the index, was associated with clinical outcomes in 6 months. So you could, dichotomize by RA pressure too, and you see the exact same finding, which I think for many cardiologists is surprising, but it shouldn't be. This was done in 2016. In 1994, Bonnero found the exact same thing. Only this time, this group is dichotomized by wedge of 16 and cardiac index of 2.6. No difference between patients who have index less than 2, greater than 2.6. But it's huge patients who invested exposing SWAN with the wedge. So that's and I think that all the doctors and know that guideline-directed medical therapy is so important in heart failure. And remember that all HFrEF patients should be on a beta blocker. And when we say beta blocker, we really mean long-acting metoprolol or CoReg. These are the medications that improve mortality in heart failure. So all those patients that are on fractionated metoprolol tartrate, they really should be converted to succinate on discharge. And CoReg is obviously a great medication, especially with those that have more blood pressure room. ACE, ARB, Entresto, preferably Entresto based on the Paradigm trial, should be given to all our HFrEF patients. Typically, what we do like to do, we don't have valsartan here at Plymouth, but if hospitals that do, they like to usually put patients on valsartan, check the copay for Entresto, and then switch the patient inpatient once the Entresto prior auth or the costs are evaluated, and switch the patients from valsartan to Entresto inpatient. MRAs, spironolactone and plerixafor, are very important. SGLT2 inhibitors are kind of the new kid on the block. They're excellent for not only diabetic patients with heart failure, but also have a benefit for just heart failure patients alone. In some instances, hydralazine and nitrates are useful. In white patients, hydral and nitrate is useful for patients who cannot tolerate ACE, ARB, and Entresto, either for issues of potassium or renal function. And in black patients, hydralazine and nitrate, based on the AHEP trial, has a benefit on top of ACE, ARB that hasn't been evaluated for Entresto yet. Lastly, we rarely see this medication, much more popular in Europe, is ivabradine, which has rehospitalization and mortality benefit in patients that have heart failure, HFpEF, but with, I'm sorry, HFrEF, not HFpEF, I should be saying HFrEF, who have maximal tolerated beta blockade, but still have heart rates greater than 70. Ivabradine has a good effect for those patients. And so GDMT, you know, we say these words, but what does it really mean? It translates to a decrease in mortality. And drugs that inhibit the renin-angiotensin system have a more modest benefit, you know, 10 to 20% reduction in mortality. But beta blockers have a huge benefit, and up-titration of beta blockers to target is very important. Up-titration of ACEs and ARBs to target is less important than beta blocker is. So a difference between lisinopril 5, 10, 20, probably not as big as going from metoprolol succinate 25 to metoprolol succinate 100 or 200. And lastly, MRAs have a mortality benefit. So really all patients that you can get, barring renal function and potassium, should also be an MRA. Spironolactone of 25 really isn't going to make you hypotensive. So if a patient has a soft blood pressure, you can usually still get them on an MRA. Entresto, you know, from the Paradigm trial is really remarkable. It has a huge benefit over ACEs and ARBs. And as you can see, the mortality benefit over ACEs and ARBs is about 20%. Remember, in Paradigm, they looked at valsartan, sacubitril versus enalapril. So you have an ARB plus a neprilysin inhibitor, which basically increases the natriuretic peptides and has a mortality benefit, has a quality of life benefit, has a benefit in so many ways. So we always try to get patients on Entresto. The one thing you have to watch out for is Entresto can make you very hypotensive. So all patients in the Paradigm HF trial had systolic blood pressures that start greater than 100. If it's less than 100, I would be very cautious in initiating Entresto. Great. All right, so summary so far: decongest your heart failure patients is the main driver of readmissions, and failure to do so is associated with death. And get your patients on GDMT. So here's case number 1, a 56-year-old woman with severe MR, status post mechanical mitral valve replacement, HFpEF, AF, status post multiple cardioversion, stroke, OSA, presents with worsening dyspnea, edema, and a 20-pound weight gain over the past 2 weeks. She's volume overloaded on exam. Her BUN and starting creatinine are 18 and 0.9. She's bolused with 120 milligrams of IV Lasix and started on a drip at 20 milligrams per hour. However, her renal function worsened. She started with a creatinine of 0.9. They're diuresing her. Her creatinine is now 1.6 on day 3. She initially put out well. On day 1, she was net negative 3 liters, but her urine output has declined. However, on rounds, JVP is still to the earlobe at 90 degrees with 3+ pitting edema and dyspnea. So now we're going to see if the polling works. Okay, so poll question: what is the next best step in management? And I'm going to launch this. So on your screen, you see the option to poll what is the next best step in management. Transition to oral diuretics because she is at her limit. Stop diuretics and give back fluid. Pause diuretics for the rest of the day and restart the next day. Rebolus IV Lasix and increase strips to 30, or right heart cath.
I like that. I like that he does that. Smart guy. I love these new smart guys. Wasn't paying attention. I would have answered it.
All right, so we have about 17 votes. It would be nice to hit maybe 20 if people are at their computers or iPhones. All right, so we're not going to get there, but that's okay. 17 people responded. Thank you. So the majority of people chose what I would chose, rebolus, IV Lasix, and increase drip to 30. You know, transitioning to oral diuretics probably isn't the right answer because she's still very volume overloaded on exam. No one chose stop diuretics and get back IVF, which is good. Pause diuretics for the rest of the day and restart the next day is not unreasonable. And I think you could argue that if you give her time to re-equilibrate, that's fine. You want to restart the next day. But you know, my choice would be rebolusing IV Lasix and increase drip to 30 because she's volume overloaded, right? Right heart cath is also not unreasonable, but unless you had some expectation that she was low output, there's really no reason to right heart cath her, I think. You know, she's massively volume overloaded. So I think you would expect her filling pressures to be elevated. So let's see what happened to this patient. So she basically was, she was, you know, kept on her Lasix drip. She was rebolused and then increased drip to 30. And as you can see, her renal function, you know, returned close to her baseline. So this is the point I want to make. Worsening renal function with aggressive diuresis is not associated with worse clinical outcomes. And this has been shown in numerous studies. This is based on the ROSE AHF sub-study by Ahmad. I looked at about 283 patients and basically dichotomized patients as having worsening renal function in the purple or not worsening. And worsening was defined as a drop in GFR greater than 20%. And what he did was he basically looked at GFR based on either cystatin C, which is panel A, or creatinine, panel B. And cystatin C, you know, in some circles would be arguably the better marker for you know, renal failure. And what he did then was he took these groups and then also looked at urinary biomarkers, very well validated urinary biomarkers that are indicative of tubular injury. These include NGAL, NAG, and kidney injury marker. And as you can see, there is no relationship between patient renal function and increase in urinary biomarkers. So whether your renal function worsened or not, there is no association between your worsening renal function and worsening kidney injury in terms of urinary biomarkers. So what is this decrease in GFR? It's non-specific. It doesn't mean that your kidneys are getting worse. It doesn't mean your kidneys are getting more injured. It just means hemodynamic fluctuations that are causing an elevated creatinine. Even more surprising is then he looked at the cumulative survival between all these markers. And look at who did the best. The patients who had the best mortality over the length of the study were patients who had an elevation in their cystatin C or creatinine and an elevation in their injury biomarkers, as compared to patients who had a decrease in their GFR, an increase in their GFR, and a decrease in their injury biomarkers. So this goes to show you that it's not that diuresis is worsening your kidneys, because if it's truly worsening your kidneys, mortality would not be best in those patients that were dried out. So diuretic-induced AKI is not associated with elevated biomarker levels. And when AKI and tubular injury occurs, it's actually associated with better survival, okay? So this is another study based on the dose trial. Briscoe did this study, and this was ACF in 2016, and basically her group found basically the exact same thing. Here is a change in creatinine on the x-axis. These are decreases in creatinine, the negative, and increases in creatinine are the positive. And this is the hazard of death or rehospitalization. And look what happens here. As the creatinine got better for patients, the hazard ratio for the primary outcome got higher. And as the patient then was at baseline creatinine or a little bit above baseline creatinine, there really was not much of a change in the hazard ratio. They found on their multivariate analysis that increasing creatinine over the first 72 hours of diuresis was actually associated with lower risk for death, rehospitalization, or PR visits. So you might ask why that is, Roy. That's like the most counterintuitive finding and paradoxical finding. You know, I think you could explain it a couple ways. You could say that those patients who had an improvement in creatinine with diuresis probably were much sicker when they came in, right? They had higher central venous pressures. They probably were more decompensated. And you might even argue that those patients who had a decrease in creatinine, they may have been prematurely discharged because people thought that, hey, their patients are doing better, they're euvolemic now, their creatinine got better, let's get them out of here. I don't know whether these are just theories, and the study didn't address whether or not that's true, but I think that those are both plausible, especially the initial ones, where patients who had decreases in creatinine may have been sicker on the start. So this is again the survival curve, right? Patients with stable or worse renal function better than patients with improving renal function over a number of days, the first 60 days after admission with heart failure. So the next point I wanted to make, right, if a patient is congested, don't worry about the small to moderate changes associated with aggressive diuresis. If they're clinically doing stable, if their creatinine is bumping 0.3, 0.4, 0.5, but they're clearly volume overloaded on exam, and you're not worried about them being low output, just keep diuresing them, and most of the time the creatinine will improve. Case number 2, we have a gentleman, he's about in his 60s, he has HFrEF, and he's been feeling a little more short of breath, more edematous in the extremities. He wouldn't have come in, but his doctor who took labs was concerned. He has CKD stage 3. His baseline creatinine is in the mid-2s, but now it's gone up to 4.7. He's got bad hyponatremia. FBP is in the 90s, and he takes 80 milligrams of Lasix twice a day at home. You do an exam, you see his JVDs up, okay? So here's the next polling question. What is the next best step in management of this patient? So is it A, give 80 milligrams of IV Lasix, B, give 160 of IV Lasix now, C, give 1 liter of fluid because his creatinine's elevated, D, start dopamine, renal dose dopamine, or E, consult renal to start CRT? So that's 16 votes so far. Give it another 20 seconds. All right, very good. So most people chose giving Lasix, which I would agree with. And if you look at the dosing recommendations for Lasix, it is to take the total dose in a day and convert that PO dose to IV. So this patient took 80 BID. So the right answer would be give 160 milligrams of IV Lasix. This guy's creatinine is also 4.7. So if you actually want to diurese him, it's unlikely that 80 milligrams of IV Lasix is going to do it. So I think giving 160 milligrams of IV Lasix is the right answer. If you gave 80 milligrams, of course, there's nothing wrong with that. And if he doesn't put out, then of course you would just so there's really in these patients at all. And then consulting renal to start CRT, he may need that down the road, but give him a shot with Lasix first and see what happens, okay? So let's take a look at what happens to this patient. So, he's over the next 3 days, remember we started with the creatinine of about 4.7, a sodium of 129, okay? We started giving him 160 BID of IV Lasix, monitoring his output. Day 2, his creatinine's 3.8, his sodium's improving to 133. Day 3, his creatinine's down to 2.7 and his sodium's 140. And his systolic blood pressure is now 110 instead of 90, right? So in these congested patients, diuresis will often improve the hyponatremia and the renal function. And just again, to reemphasize, congestion in and of itself worsens renal function. This was a study by Firth and Lancet who took animal models, I think it was canine and rat, and basically looked at these renal parameters based on venous pressure. He basically Unfortunately, volume overloaded these animals with CVPs from 0 all the way to 25. This is 0 just as a marker. And as you can see, what happens when the CVP goes to 25? Sodium excretion decreases, renal blood flow decreases, fractional excretion of sodium decreases, GFR decreases, right? Everything worsens when a patient's volume overloaded. Mullins took about 40 or so patients and measured intra-abdominal pressure and baseline serum creatinine. And not surprisingly, those patients that had high intra-abdominal pressure had worse creatinine than patients with lower intra-abdominal pressure. Okay. Another study that was done by Mullins in 2009, looking at congestion and renal function, and those patients with a CVP of greater than 24 or 16 to 24 did much worse in terms of worsening renal function during the course of admission than those patients with CVP less than 8. And these patients all had SWANs in this study, and prior to SWAN removal, again, a high CVP, worse GFR, index matters less for renal function than filling pressures. So the question some of you may be asking, why does renal function often improve with diuresis, right? Like when you were an intern or a med student, whenever someone had AKI, all people taught you was to give fluid. But then you did your cardiology rotations and you realized that fluid actually in a patient can actually kill them if they're very volume overloaded, right? And so remember that perfusion across any organ is the map minus the venous pressure, right? When a patient has a stroke, why do we keep the blood pressure permissively high after an ischemic stroke? Because you want to perfuse the brain. Whenever you have hypertensive emergency, and you can only bring the blood pressure down by 10 to 20% in the first 24 to 48 hours. Why is that? Because you don't want to shock the kidney that's used to a high MAP, right? So it's the same for the kidneys in heart failure, right? The perfusion across the kidney is what's going in minus what's going out, the renal artery minus the renal vein. So normally, right, heart failure patient MAP is kind of low, 70, but central venous pressure can be very high, let's say 20. Your perfusion pressure is about 50. Now you have a patient who gets diuresed. What's their perfusion pressure going to be? You get the CVP down to a normal level, like 5, 6. All of a sudden, their perfusion pressure improves to 65, right? And the kidneys are much, much happier. The macula densa is happier. The baroreceptors are happier. The kidney tubules are happier. Everything's happier. The kidneys start working better, okay? And why does renal function often improve with diuresis as well? Well, it's because of what's happening in the heart, right? This is a normal heart on your left in cross-section, parasternal short axis. You can see the LV. It's a nice circular shape. This is the LV. This is the way the LV was made. This is what the LV wants to be like. And the RV is a crescent shape around it, okay? Patients start getting tanked up. What happens to their RV? The RV starts dilating. It starts pushing the septum into a D shape, okay? This is not the normal configuration of a happy left or right ventricle. How can a left ventricle possibly fill whenever the right ventricle is pushing it so far? And how can a left ventricle squeeze and have an effective systole if the septum is all the way over shifted to the left, right? So what you do is you diurese patients, you restore their normal geometry, and all of a sudden the heart's a lot happier and the kidneys are happier too. So you improve ventricular interdependence with diuresis. And that's why in these patients who have severe RV volume overload, it's not uncommon to see blood pressure increase with diuresis in this population. Remember, the kidneys are stupid. They treat volume depletion and overload the same, right? No matter if you're in fluoride decompensated heart failure or you're dry because you've been on a desert for a week, the kidneys have no idea what's going on. They treat both situations exactly the same. Urine sodium is low because aldosterone is high, and urine osm is high because ADH is high. Why? Because in both states, the kidneys sense low perfusion. They're like, I got to accumulate sodium. I got to accumulate fluid. They're going to turn on aldo and ADH. In fact, in residency, I had David O'Halloran once said, if another resident orders urine light on a patient with heart failure for hyponatremia, I'm going to throw a book at them. And the reason he said that is because it doesn't help you. In heart failure, you already know what the urine lights are going to be. There's really no point in ordering them. So you can do it for academic purposes and to prove it to yourself. But the aldo is high and ADH is high. It looks exactly like a patient who's dry, okay? When you improve renal perfusion, you decrease the stimulus for ADH and aldosterone release. And that's why the hyponatremia will typically get better when you diurese patients who are in pure volume overload heart failure. Low output is a different situation. When you throw cirrhotics into this, it's a different situation. But just for wet patients, this is why you need to treat their volume overload. So next points I want to make is that managing chronic heart failure is about counteracting the vicious neurohormonal cycle, right? In heart failure, everything is ramped up to a deleterious effect, right? Your RAS system is ramped up, catechols are ramped up, ADH and aldo is ramped up, okay? What we're trying to do is we're trying to get rid of that. We're diuresing them to decrease ADH and aldo. We're beta blocking them to decrease the catechols. We're using ACE, ARBs, and Entresto to decrease the RAS system. We want to counteract that milieu to save the heart. And you must do a good physical exam for volume status. Okay, this was a very simple study done by Drasner about a couple decades ago, looking at stratifying patients by JVD, elevation or not, third heart sound or not on admission. And look, not surprisingly, those patients that have elevated JVD, that have a third heart sound, do worse than those patients that do not. On multivariate analysis, adjusted for age, EF, NYHA class, sodium, creatinine, et cetera, those patients that had either an elevated JVD or an S3 did worse in terms of death and CHF hospitalization. So the question remains that it's not that easy. Everyone's had experiences here where you have a volume overloaded patient, or you think you do, and you diurese them, and they don't react the way that you expect. Mind you, when I say they don't react the way you expect, I'm not talking about a creatinine increase of 0.3 or 0.4. I'm talking about they're not putting out, they're feeling worse, they're getting lightheaded, they're getting hypotensive, their creatinine doubling, right? We've all dealt with those patients. And so that, hopefully you would consult me. You might consult renal if their creatinine is getting really bad. Whatever the case may be, you have to understand why this might happen and what your options are, okay? And one, your exam is just wrong, okay? You think you're looking at JVD, but you're looking at carotid, right, or something of that nature. You think you're looking at edema from heart failure, but you're looking at edema from cirrhosis or hypoalbuminemia, okay? And so you're diuresing a patient that isn't exactly wet. Two, the patient's an RA to wedge equalizer. I'll explain what that means. Three, the patient's ventricles are stiff and non-compliant. I'll explain what that means. And four, the patient is low output. It is very hard to diurese a patient that is cold, and they're going to be sick because they're sick. So one, your exam is wrong, right? The obese patient, it is difficult to evaluate JVD. It can be difficult to differentiate adiposity from edema. Two, not all edema is from intravascular volume overload, right? Venous stasis insufficiency, cirrhosis, right? In cirrhosis, where is your lesion? It's the liver. So of course a patient can have ascites. Of course a patient can have profound lower extremity edema, but their central venous pressure should not be elevated. If your central venous pressure is elevated in cirrhosis, that means that there's something wrong with the heart. That can't just be from the liver, okay? Vasodilators such as hydral and lodipine, right, can cause edema, hypoalbuminemia, of course, and lymphedema, right, in patients who have had surgery, who've had malignancy. You should watch out for that. Two, I mentioned RA to wedge equalizers, right? So what does that mean? What am I trying to get at here? Remember, why do we measure the wedge? Why do we care about what we call the left ventricular end diastolic pressure? Well, to get back to basics, it's really all about the Starling curve, right? If your LV-EDP is all the way out at 20, 25, a patient's shortness of breath is probably from their high wedge. A patient's hypotension is not likely to improve if you give them more fluid. If a patient's LV-EDP is 0 to 5, 0 to 10, it's unlikely that their shortness of breath is from the heart. It's cardiac related. It's unlikely. It's likely that their hypotension will improve with fluids, right? And obviously I'm simplifying here. But basically we measure the wedge to try and get a sense of where patients are on the Starling curve. But I have no way of knowing what a patient's wedge pressure is without doing a right heart cath, right? So all of us on our exams, we use the RA pressure as a surrogate for the wedge pressure, which is a surrogate for the LV-EDP, okay? So the questions that you should all be asking yourself is it reliable to estimate the wedge from the RA? And the answer is yes. This is another study by Drasner. And he put patients in groups based on SWANs, RA greater than or less than 10, wedge less than 22 or greater than 22. And first he looked at what segments were concordant, right? So these are 1,000 patients. And if you look, about 80% of the time, patients are concordant between their wedge and their RA pressure, okay? That means you have a high wedge, you have a high RA. You have a low wedge, you have a low RA, okay? And about 80% of heart failure patients, the wedge is about twice the RA, right? Your RA is 10, your wedge is likely to be about 20, 22, and if I diurese you, you should improve, okay? But look at these discordant 2x2 areas as well, right? There are about 62 out of 1,000 patients that are RA to wedge equalizers. That means their wedge is much closer to their RA. So imagine this situation, right? You're diuresing a patient and you're like, oh, their RA is, probably still 8 or 9. I still have room to go, okay? They have some edema, but their wedge is also only 10 or 11, right? And every time you diurese that patient, they're getting hypotensive. They're like, I feel really sick. They're not putting out, their creatinine shooting up. This could be one reason for that, okay? I just want to point out there's this other discordant group as well, high wedge, low RA. These are the patients that may have bad LV systolic function, maybe an anterior MI, but their RV is working well. And so you look at the patient, you're like, they seem dry. They don't have edema. Their, CVP looks low. Why are they so short of breath? And in that case, it could be because they're discordant in the opposite direction. So the ventricles are stiff and non-compliant is another reason why you can have trouble diuresing a patient, right? So normally, our hearts are like balloons. They accommodate volume quite well, okay? And if you look here, what happens when you have a decreased compliance? Let's say your heart's very stiff, right? You've had years of LVH. Your LV walls are 1.5, 2 centimeters. You have hokum, you have amyloid, whatever the case may be. A normal person, right? Let's say an EDP of 10 or a wedge of 10, your end diastolic volume, let's say, is about 110 cc's of fluid, right? That same EDP in a patient with decreased compliance may only be 50 cc's of volume, okay? So basically, these patients, they have very high filling pressures. So in order to fill their ventricle, they have to live with higher filling pressures. Otherwise, the heart doesn't fill, and there's not enough stroke volume to the brain and to the kidneys and to the liver, okay? So the classic example of this is restrictive cardiomyopathies from amyloid, right? End-stage amyloid patients with very thick walls and are acting very restrictive, it is very hard to diurese them. They may need to live with a wedge of 20. They may need to live with an RA of 10 or 12. And sometimes diuresing them, even though they have edema, you got to have some discretion because they could easily go the other way, that when you take away their volume, they literally cannot fill, okay? This is in contrast to patients that have increased compliance, right? These are patients that are remodeled, chronic heart failure patients, right? I can take 10 liters off a patient that has a dilated LV and RV and not bump their creatinine and not drop their blood pressure. Why? Because they have so much extra volume and their heart is baggy and saggy. And when you take that volume out, the heart still basically doesn't get affected that much. And that extravascular volume just repletes the intravascular volume. And those fluctuations in the patient's volume doesn't really affect the patient's hemodynamics. This is what happens when a heart remodels, right? Normal, you have this compliance or end diastolic pressure volume relationship. And over time, after you have an acute insult, the heart remodels so that sure, inotropy increases, but these patients are operating at a much higher volume point for these same pressures. This is why you can take tons of volume and you don't have to worry about over-diuresing patients who are chronically remodeled in this way, as opposed to a restricted patient. Lastly, the patient has a low cardiac output to make it really hard to diurese the patient. And if a patient's obviously low output or in cardiogenic shock, right, you got to warm that patient up before you can do anything with them, okay? So these are the Stevenson classifications that hopefully most of you have heard of. Very simple, right? When you evaluate a patient on physical exam, you're trying to look at LV filling pressure, normal or high. You're trying to look at index, normal or low, okay? Warm and dry, category A. Warm and wet, most of our heart failure patients warm and wet, category B. Cold and dry is much rarer, but can occur. And cold and wet is the worst prognosis, right? Your perfusion stinks and your filling pressures are high, classic kind of low output syndrome. Okay? So how do we know someone's congested? Well, we do physical exam, right? Orthopnea, high JVP, S3, edema, ascites. I just want to put out RALs and a wet chest X-ray in a chronic heart failure patient occur only in about 20% of patients. So, you know, I never want to hear someone say this patient isn't volume overloaded because their chest X-ray looks clear and I think their lungs are clear. That's just not true. You know, the pulmonary lymphatics accommodate a lot of volume over time and they remodel. So really, the chest X-ray and RALs, sure, they're going to be present if a patient has an acute insult or they had a hypertensive emergency and they're not used to seeing high sibling pressures. But over time, RALs and wet chest X-rays go away as the patient has longer standing heart failure. And evidence for low perfusion, you know, you must touch your patient's forearms and legs. If they're cold, they're cold. If they're lukewarm, they may be cold. Okay, narrow pulse pressure gives you a clue. Being sleepy or tunded, not tolerating GDMT due to hypotension, decreased serum sodium level, and possibly worsening renal function. You diurese the warm and wet patient. For the cold and wet patient, you want to diurese them, but often they need an inotrope or a vasodilator first if they have blood pressure. So hemodynamic profiles predict outcomes. Not surprisingly, the patient who is cold and wet does the worst. The patient who is warm and wet does a little bit better, and the patient that is warm and dry is what we aspire to make our patients. So categorize your patients as wet versus dry and warm versus cold by exam and history. If a patient is not acting the way you expect, you have to think, you have to ask yourself why. And I would always appreciate those consults and to help you think through any of this, okay? So this is a tough case, and I just wanted to bring it up because I thought it was interesting. We saw this patient in Boston a week ago. So he's 63, type 2 diabetic, Hep C status post-treatment with known liver fibrosis, presents with worsening dyspnea. He's very volume overloaded on exam. His JVP is greater than 20, he's got crackles, he's got 2+ edema, his extremities are cold, he's alert and in no acute distress. His vital signs are as follows. His blood pressure is pretty high, 133/98, which is very surprising. His TTE, though, shows that his EF's only 15%. His RV is decreased in function, and he's got severe MR and TR. His SWAN numbers are pretty horrendous. His RA is 26. His wedge is 40. You know, RA should be about 5. Wedge should be less than 15. His SVO2 is 33% with an index of 1.6. That's very abnormal, right? Normal index greater than 2.2. And his SVR is high, 1900, right? Normal index is about 1000, 1200 or so. His Chem7 doesn't look bad. His white count's high, his platelets are low. And his liver looks terrible. His AST, ALT are in the 2000s, and his lactate is 12. But he came in talking. He's alert. He doesn't appear to be in distress. But his lactate is 12. So interesting case, right? So what's the next best step in management for this patient? Okay. So is it aggressive fluid resuscitation, start inotrope, afterload reduction with nipride, or mechanical circulatory support? And for some of you who've never dealt with this, don't worry, just put an answer. No one expects you to know what to do in this situation. I think different people might choose different things. All right, great. Got about 17 votes or so. I'm going to end polling now. Okay. All right. So we have about an even split between inotrope and afterload reduction. Let's see what we did here. So whatever we did, you know, the lactate was 12 or so, and then over the span of a couple of days went down to 2. And we started this patient on nipride. And the reason is because the patient had blood pressure room, 133/98. And, you know, mechanical circulatory support, this patient definitely has low output. But you have the blood pressure of 133/98. So you have blood pressure room to work with. So really afterload reducing is the best thing. Inotropes is not unreasonable, and I think would be fine too. But in general, when you have that blood pressure room, starting an afterload agent is a good way to go. The reason the patient's blood pressure is so high, despite such a crappy heart, is because the SVR is so high, right? The SVR is about 1,800 to 2,000 or so. And so just afterload reducing in a number of patients, the heart function will improve, the stroke volume will improve, and organ perfusion will improve. So this is kind of the main study that looked at nipride for advanced low output heart failure. Again, Mullins out of Cleveland Clinic, and basically showed that in patients treated with nipride versus not, in this subgroup of patients who all had blood pressure room. I mean, their starting SBP was greater than 110, so it's a unique group of patients, right? That freedom of all-cause mortality was better. And as we know, inotropes are great in the acute situation, but you don't want to put them on long-term. Again, I don't think inotropes is wrong in this case, but if you have the blood pressure room, nipride is a good option. So other than meds, what else is there that we can help patients, give patients to improve their quality of life and their mortality? Cardiac resynchronization therapy obviously is great, and a number of landmark studies in the early 2000s. This is Companion, this is CARE-HF. It basically showed that in patients who had a left bundle and EF less than 35%, that putting in a CRT is associated with really improved survival, less readmissions, and greatly improved quality of life. And interestingly, if you look at any of the studies, even though they haven't necessarily randomized, if you look at CRT-D, defibrillator versus pacemaker, the defibrillator doesn't seem to make much of a difference in terms of survival. So a lot of this is heart failure mediated. Just improving the resynchronization in and of itself seems to be sufficient to improve outcomes in heart failure patients, right? The patients that have the best outcomes with these, patients that have left bundle branch block, QRS greater than 150 are those patients. Okay. And MitraClip, which you've all probably heard a lot about in severe secondary MR based on the COAP trial, right? I want to remind you, MitraClip, it's a pretty simple intuitively to grasp, right? You cross the intraatrial septum and you put a chip clip, a little more complicated than that, but what amounts to a chip clip across the mitral valve, and it basically reduces the amount of MR. And in the trial looking at COAP in 615 patients with symptomatic heart failure and moderate to severe MR, secondary MR, randomized to MitraClip plus medical therapy versus medical therapy alone, huge benefits, right? Hospitalization for heart failure dramatically reduced. Death from any cause, 29% in the device group versus 46% in the control, right? So it's not for every patient with secondary MR, right? We learned from the MITRA-FR study, which was done in Europe, that there's a subset of patients that don't respond to MitraClip. So you have to choose the right patient, and choosing the right patient goes beyond the scope of this talk. But just remember that when you see severe or moderate to severe MR, MitraClip can really benefit certain patients. So we have a 68-year-old woman. She works as a banker. She has longstanding HFrEF from ischemic cardiomyopathy. She's active and takes her dog for 2-mile walks each day. She presents after having an appropriate ICD shock for VT, but interrogation reveals several non-sustained episodes of VT as well. She denies chest pain or dyspnea. However, she has had to progressively decrease her medical therapy over the past few months due to hypotension. In the hospital, her blood pressure is 90s over 60s, and initiation of GDMT causes her pressure to drop to the 80s. Tropes are negative, ECG is unremarkable. She has elevated JVD, kind of mild edema, clear lungs, and lukewarm extremities. Echo is similar to prior from a few years ago. So what's the next best step in management? This lady who had a VT shock, doesn't complain of many symptoms, has a lukewarm on exam, elevated neck veins, and getting hypotensive whenever you start GDMT. So is it fluid resuscitation for hypotension? Continue to hold meds and discharge with close outpatient follow-up. Retry GDMT or right heart cath. give 5 more seconds for people to respond here. And thank you everyone for participating. I hope it helps and makes it more enjoyable. All right, I'm gonna end polling here. All right, so most people chose right heart cath in this lady who had some concerning findings, right? She says she walks with her dog 2 miles each day, but she really can't tolerate any medical therapy. And all of a sudden she's having more VT, right? So let's see what we did. We did a right heart cath, okay? And of course, you know, RA is 18, wedge is 33, right? Her lungs are clear, don't let that fool you, right? Her PA stat's 33% here, and her index is 1.6. So what did we do for this patient? We gave her inotropes, and then she ultimately was listed and went to transplant on that same hospitalization and has done remarkably well. Even though she's 68, got a transplant, goes to Steeler games, not now during COVID, but before COVID, and has done extremely well. So remember, you got to be concerned about advanced heart failure when patients are giving you clues that they have advanced heart failure, okay? And so I like the ESC definition, right? Severe and persistent heart failure symptoms, right? She says she's walking her dog, you know, but if you press her, she's like, I actually am getting more short of breath. You know, I have to cut my walks shorter now. I used to be able to walk them, you know, 3 or 4 miles. Severe cardiac dysfunction, episodes of pulmonary systemic congestion requiring high-dose diuretics or inotropes, or malignant arrhythmias causing more than 1 unplanned visit or hospitalization in the last 12 months, and severe exercise impairment, either by low 6-minute walk test or a low peak oxygen consumption, okay? The clues to low output heart failure and to advanced heart failure, repeat hospitalizations, progressive deterioration in renal function, cachexia, intolerance to ACEs or beta blockers, frequent SBP that's low, persistent dyspnea, inability to walk 1 block, needing to escalate high-dose diuretics, progressive decline in sodium, and frequent ICD shocks. You know, whenever one of these is occurring, it should just cross your mind. Maybe you refute it in your mind and say they don't have advanced heart failure. But then if they start acting in a way that you don't expect, it is correct to consult, it is correct to right heart cath this patient, because as we know, our exam for low output heart failure is not great. Feeling the extremities, if they're cold, they're cold. If they're lukewarm, they may be cold. And even if they're warm, we're often wrong about it. Okay? We think they're warm, but they're actually not. So stable versus end-stage heart failure, right? On one end, these stable patients, they're going to do fine. You up-titrate their GDMT. They feel well. They see you in clinic, okay? But patients who are advanced, right? Within 2 years, these patients are going to be dead. Within 6 months, these patients, over half of them are going to be dead, okay? They need other things. So you got to mind the gap, right? Treat these patients as they should be treated. Don't treat these patients just with meds. Life expectancy, palliative inotrope, 9 months. Life expectancy after a heart transplant, 11 years. And I want to say that the goal at Plymouth is to get patients that have had transplants, and we take care of them at Plymouth. With the heart failure clinic opening up, hopefully in a couple of years, we can take care of these patients and taking care of bad patients too. I do want to see those patients in my clinic, and that's the goal. And so I hope, you know, to get all of you some exposure whenever we start doing those sorts of things. And I'm always happy to talk and teach about transplant bad, because I think probably many of you are very interested in what that looks like. So as you know, getting a heart is great, new lease on life, right? But not everyone can get a heart. Even for the sickest of patients, this is outdated, but it takes a long time. In our area, for whatever reason, 413 days for sick patients to get a heart. And if you're blood type O, if you're large, it is very long to wait for a heart, right? It's better in some areas, right? Probably good to live in California or Arizona, okay, if you need a new heart. But look at these curves, right? Optimal medical management in sick advanced heart failure patients. It's just not going to work, you know. And so if you can't get a transplant, getting a VAD is a good option. Okay? VAD will give you a 2-year survival of about 70%. Median survival for VAD now is above 4 years. And so intermax level is a different way of thinking about heart failure in patients that need mechanical circulatory support. Level 7 advanced class 3 patients all the way up to level 1, which are crashing and burning. Patients that you should start thinking about advanced options start at level 7, but we basically implant VAD definitely at level 4 and you know, below. And level 3 used to be kind of the optimal, but now we're pushing to level 4 as being the optimal place to refer patients to VAD. What you don't want to happen is you don't want to sit on patients too long, right? You sit on a patient too long who's in advanced heart failure, their kidneys are going to go, their liver is going to go, they're going to get more cachectic. They're not going to be an option for VAD and transplant. No one's going to take them because they're too sick. So you have to refer early when you think that patients are starting on this trajectory. So this is survival for LVADs, most recent Cormos JHLT. And look, at about 4 to 5 years, these patients are living about 4 to 5 years, 50% median survival. We wish this could be 7 or 8 years for VADs. We're not quite there yet, but the new generation VADs, especially HeartMate 3, looks very good. And I wouldn't be surprised if we push the survival up to 5 or 6 years with the new HeartMate. So how do I know a patient should be referred to a heart failure specialist? I need help is the mnemonic I want you to remember. Inotropes, NYHA class 3 or 4, and persistently high BNP, and organ dysfunction, very low ejection fraction. I want to see these patients. Defibrillator shocks in consultation with EP, hospitalizations, more than 1 from heart failure in the past 12 months, edema or escalating diuretics, low blood pressures, and inability to uptitrate or need to decrease GDMT is a sign that this patient really has advanced heart failure. And that was what was seen in our last patient that got transplanted, right? Couldn't tolerate any GDMT. How are you going to make that patient better if you can't put them on medications? And the VT, right? You have to think about whether the patient needs advanced options. So just really shortly, I know I'm over my time, but discharge criteria for heart failure patients is important, right? We got to get them dry. You got to have them 24 hours without changing oral heart failure regimen. Sometimes if a patient's been here really long and is really antsy to go, we kind of say, okay, we'll let you go. But kind of recognize in your mind that we're not really technically doing the right thing, and that does increase their risk for readmissions. And you want to keep an even fluid balance on oral diuretics, right? You want to get them dry and then put them on a maintenance diuretic. And if they're increasing their weight overnight by 2 pounds, you know that oral diuretic is not going to do anything for them. They're going to go home and they're going to be right back within a week, right? By the same token, if you put them on oral diuretics and they just peed 3 liters overnight, if you send them home that they're going to come back with an AKI and lightheadedness probably in a week. So that's why you want to keep them about that even on orals, right? And some patient family education is great, flexible diuretic plan. And really the key is a clinic appointment within 5 to 10 days. When I set up my heart failure clinic and it's going, we're going to try and get all patients who are discharged to be seen in clinic within 10 days. BI-Plymouth has a great infrastructure led by Jimmy Bergelli and Jill Whalen had done a lot of work. Rob Cosiel had a lot of the nurses and case management in putting together a great packet that patients are getting as to educate them as to what it means to go home with heart failure. And to really, if you gain 3 or more pounds in 2 days or 5 or more pounds in 5 days, right? That's not because you're eating more in terms of like muscle mass or adiposity, that's fluid. So having those patients know to call me or their PCP is very important. And, this is a great sheet too, telling the patients to weigh themselves every day. For all the hospitalists that are listening, if you could reemphasize when we discharge, I try to tell all the patients that weigh yourself every day and fill out this chart for daily weight and blood pressure. That would be immensely helpful. So the summary, last slide. Thank you all for listening. Decongest your heart failure patients. Get your patients on GDMT. Don't worry about small to moderate changes associated with aggressive diuresis. Counteract the vicious neurohormonal cycle with appropriate medications. Categorize your patients. Do a good physical exam. Train yourself to think, is this patient wet or dry? Is this patient warm versus cold? If based on your clinical assessment and your treatment, the patient's not acting the right way, reassess why it's so. Ask your colleagues for help. You can Volt me, you can email me, anytime. I'm happy to see any patient. Recognize the advanced heart failure patient and promptly refer to advanced heart failure using the I need help mnemonic. This is a big push. I don't want to miss any patients that could get advanced options. I don't want a 40 or 50-year-old who could have gotten a transplant not get one because we waited too long. There's really no reason now where patients less than 70 who have good organ function other than their heart should die from their heart. We have too many options now so that doesn't happen. CRT and MitraClip have significant mortality and quality of life benefits, and VAD and transplant in the appropriate patient can give someone a new life. Refer early. Right. Thank you everyone for listening. If you have any questions, I can take some in the chat, or you can always email or Volt me. And for those I haven't met, I hope to meet you all soon. Thank you.